just before last week. So can we go to second slide, Dr. Pandit? So this is a 37-year-old Itoke female who is a domestic housewife with nil comorbidities. So she presented with chief complaints of dull lower abdominal pain, bleeding during defecation, occasional diarrhea. On further asking, she also said that she has tenesmus and increased frequency of bowel movement. All this just within 5 months period. Before 5 months, she was all good.
Yes.
On review of system, she did had loss of appetite and loss of weight, but otherwise no other significant symptoms or sign of other system.
Okay.
She past medical history, there is no history of polyps or ulcerative colitis or any other malignancies. She was never admitted before. Family history, she doesn't remember or doesn't know anyone having any sort of cancers. And she's a non-smoker, non-alcoholic, and on ONG history is unremarkable. On examination, she wasn't in any discomfort. She was alert oriented, no jaundice, but there was definite conjunctival pallor. Abdomen was soft, non-tender. However, she did had about a 10 centimeter mass felt at the left lower quadrant, which was non-tender. On DRE, a mass was felt at the tip of the finger, but we cannot reach the upper margin of that. It was non-tender and there wasn't any blood on the glove. The ONG reg did a vaginal examination, which was unremarkable from their side. On investigation, so she had a HP of 7.8, a CA slightly elevated 6.7, and LFTs was normal. She had a colonoscopy done, which showed a circumferential lesion starting 7 centimeter from anal verge, extending to 15 centimeters. And it was a cauliflower lesion with contact bleeding. The instrument was inserted 80 centimeter to the distal transverse colon. However, because of the contact bleeding, we didn't proceed further. So we did a CT scan. I think that's just a picture, Dr. Paran, it's just not a video. So on CT scan, the official report is yet to come. We were planning to do a MDT yesterday, but it didn't happen. So, however, verbally, what the team from, we are also connected with the team in Melbourne who helps with our CT reports. So they have said that it looks like primary rectosigmoid malignancy, and there is no intrathoracic or intra-abdominal metastatic lesion. But yes, we are waiting for the formal report to see the extent and do the TNM staging. However, they are thinking that it looks more of T4 on the CT. And the histology has came as adenocarcinoma, but the grade is, we still don't know the histological staging. But looking at the slide, it's quite undifferentiated, but yes, so the histological staging is yet to come.
Okay.
So current plan is, our plan was to get to do an MDT discussion and then think of doing probable MRI pelvis, do a family conference, and then optimize patient for neoadjuvant and surgery.
Yeah. So what do you think? And again, we'll talk about this in the presentation I've got, Dr. Hardik. But what do you think the best? So essentially, this is a lady that's got a primary rectosigmoid tumor with no evidence of metastatic disease on CT scan, correct? So what do you think? What are the treatment options that you're considering for this lady?
So number one is since it looks like that it's a T4 tumor. So I'm thinking of going with the neoadjuvant chemoradiotherapy, but we don't have radio here. So neoadjuvant chemoradiotherapy to decrease the size of the tumor and then following that we can go with the surgical option, probably ultra low resection or APR. So.
Yeah, and so the MRI, what's the role of the MRI scan? What are you looking for on the MRI scan to try and help your decision making?
In MRI scan, we want to see the MRF, the mesorectal involvement of mesorectal fat or the circumferential margin to see the local spread of the local invasion of the tumor.
Yeah, so that's one. So you want to know what the T stage is. So what the radiological T stage is, which is related to its invasion into the mesorectum. But also you want to know about nodal disease as well, and whether or not the MRI shows whether or not there's any nodes that are involved, because that will influence the decision for neoadjuvant radiotherapy. What do you think in this patient specific circumstance, what do you think the issue will be with giving radiotherapy? Why might this tumor? Yes, do you know what I mean? So essentially, we'll talk about this as well, but do you know what I mean? The gold standard of treatment is giving radiotherapy to rectal cancers that are T3, T4, or have nodal disease. Okay, so this looks like it's going to be an advanced tumor, but why may radiotherapy be difficult to give in this situation? Anyone else? Who else? Does anyone else have any other thoughts to help out on this? Dr. Salesi, why may radiotherapy be difficult to give in this situation?
Thank you. Radiotherapy would occur by causing DNA damage to cells, and then the cancer cells will repair itself slower than the normal tissue. I cannot think of anything apart from local damage to healthy tissue. Seeing she's a girl, she might have damage to her ovaries.
Yeah. So what other? So the main, yes, that's you're definitely on the right line. So the damage to surrounding organs is the main side effect of radiotherapy, and that is why that we give radiotherapy with tumors below the peritoneal reflection. Okay. That's rectal cancers that are below the peritoneal reflection. Radiotherapy is good because it's very difficult to give radiotherapy to tumors above the peritoneal reflection, because small bowel will be down into the peritoneal reflection and will be therefore involved in the radiation field, and you can get a whole lot of complications with a radiating small bowel. So as a general, do you think, Dr. Hardik, do you think this tumor is all going to be below the peritoneal reflection?
It's 7 centimeters from the anal verge. So yep. I'm suspecting that it's in the lower third of the rectum, and I think it's below the peritoneal reflection.
But where does it extend to?
It's from 7 centimeters to 15 centimeters, going all the way to rectosigmoid.
Yeah. So where would you expect, just in general terms, where do you expect the peritoneal reflection to be in this patient? At what level? Around about?
So peritoneal level would be, so usually peritoneal reflection is on the upper third of the rectum.
Yeah. At about how many, on average, how many centimeters from the anal verge?
So 12 centimeters.
Yeah, exactly. So the issue is that this tumor extends to 15 centimeters. This tumor, depending on the MRI, I think there will definitely be, this tumor will extend above the peritoneal reflection, which in our circumstances, we discussed this case in the MDT, but because of that situation, because it extends above the peritoneal reflection, there may be issues in giving the patient radiotherapy. Does that make sense?
Yeah.
Yep. So that'd be something that we would discuss in our MDT if we were looking after and treating the patient, and discuss that role. What operation are you planning on doing on this patient?
So I was thinking that since it's 7 centimeters from the anal verge, it's in the lower third of the rectum. The two main options would be, one is ultra low anterior resection, or doing APR,
yep.
depending, yes.
On a range of different factors. Yep, good. Spot on. All right, good case to introduce. Dr. Hardik, if you're happy, I'm going to share my screen and put up my presentation now.
Yes, thank you.
Dr. Parnik, can you enable me to share my screen, please?
Yes, go ahead.
All right. Can everyone see my slides now?
Yes, we can.
Yes.
All right. So this is a cancer on rectal cancer. We'll go for about 45 minutes. I'm going to talk about some of the principles of treatment of rectal cancer. We're going to go through some of the anatomy, epidemiology, pathophysiology, workup, staging, and then subsequent treatment options. These are three key principles that I think are very important in dealing with the treatment of rectal cancer, and three principles that I think we always think about in dealing with rectal cancer treatment. One is that of total mesorectal excision. Secondly is thinking about whether or not we can preserve sphincters, which is always an important consideration, our operative choice. And then third is the use of multimodal therapy. We've covered that briefly in our discussion, talking about neoadjuvant radiotherapy and the use of adjuvant chemotherapy as potential options for treatment. And I know that radiotherapy isn't routinely available in Fiji, but I think it's still, I was speaking to Sonal, and Sonal said it was something that is still expected of you guys to know, so something that we'll cover from our treatment here. So I think to start with, this is again recapping the anatomy of the rectum. So this is an organ that is from 12 to 15 centimeters long. We divide it into thirds between the proximal, middle, and distal third. And depending on the patient age and gender, those thirds are divided into 4 or 5 different centimeters. We'll talk about the relation of the peritoneal reflection to the rectum. And then obviously the sphincter complexes is important to consider. We have the internal sphincter, which is a continuation of the outer longitudinal muscle of the rectum. And then the external sphincter, which is thought of as a continuation of the levator ani muscle that comes down and cups underneath the internal anal sphincter. Blood supply. Dr. Ashneel, can you tell me about the blood supply of the rectum, please?
Sorry, as stated in the diagram, I think the superior 1/3 is supplied by the inferior mesenteric artery.
Yep.
And the middle and the lower 1/3 is supplied by the internal iliac artery. Branches from there, goes to the.
Perfect.
So they have separate blood supplies. Yeah.
Yeah, and so that's when, again, that we often think about that nodal disease is most likely in rectal tumors to spread along throughout the mesorectum and then along the inferior mesenteric artery and para-aortic nodes. However, something that is also worth considering, and something that we do see, is spread along the internal iliacs as well, in line with that iliac blood supply. Again, this is just recapping some iliac anatomy, which I think everyone will be familiar with. I just thought I'd recap, and again, something that's very important, or someone can tell me about this, is we'll go back on this. Dr. Manisha, can you tell me about where the, obviously, consideration of where the SMA and IMA anastomose is important when considering our surgical reconstructive options? Tell me where is blood, or at what points in the bowel does the SMA and IMA blood supply cross over? We've got everyone know. Can we go with Dr. Javili? Can you tell me about where the SMA and IMA blood supply crosses over?
Hello. Well, I think anatomically it's around the mid transverse colon, in the proximal 1/3 up the transverse colon. The arcade of Drummond is usually around near the splenic flexure, is it?
Yep, correct. Yeah, so that's the marginal artery of Drummond. Yes, correct. And do you know about another possible point where the SMA and IMA blood supply crosses over?
Sorry. The only point that I know is between the proximal 1/3 of the
Yes.
Yes,
You're right there. So it's the marginal artery of Drummond here, which is the marginal artery, the common of the colon. Griffith's point is the point where these two marginal arteries anastomose, and it's that watershed area at the splenic flexure, which we spoke about. The other thing is that there's also often an arc of Riolan, which is variably present in people, but that's closer towards the root of the mesentery, where again, the SMA and IMA blood supply will cross over. But it's another point of potential point of anastomosis. I'm just covering some key points that I think is relevant here in anatomy and things to recap. The rectosigmoid junction. So this occurs at about the S3 vertebral body, and this is where the sigmoid colon will turn into the rectum. So the three key changes that we think about is, one is you've got loss of mesentery. So the sigmoid colon is obviously on a mesentery, but the rectum is not. The tenia coli flatten and fuse to form a continuous outer longitudinal muscle layer, and you get loss of the epiploic appendages that are on the sigmoid colon but are not present on the rectum. Rectum peritoneum. Someone can, this is we briefly talked about this. Dr. Manoa, can you please tell me about the peritoneal coverings of the rectum? Did we just lose Dr. Manoa? Yes, we did. Dr. Uriam, can you tell me about the peritoneal coverings of the rectum? Not answering. Dr. Hardick, we're back to you. Tell me about, we talked about briefly, but tell me about the, can you tell me about the peritoneal covering of the rectum?
Yes, sir. So the endoperitoneum divides into two.
Yep.
Pushed in front of the sacrum is the presacral fascia, and then at the back of the rectum, it's a rectal fascia, and anteriorly in male, it's between the bladder and the rectum. And
we're talking about the visceral peritoneum. What parts of the rectum are covered by visceral peritoneum?
Is it so? The upper third of the rectum is covered with the visceral peritoneum.
Yes. And the upper third of the rectum, is all of the rectum covered with visceral peritoneum?
I'm not very sure, sir.
No, that's fine. So this is diagram here. So the way that I think about it is that this is the upper rectum here. So the upper rectum here is covered on three sides. So the upper rectum is covered by peritoneum on anterior, and laterally, but there's no peritoneal cover posteriorly. Then the middle rectum here is covered anteriorly by peritoneum, and then the lower rectum is completely extraperitoneal. Okay, so again, think about, upper third is anterior and lateral covering of peritoneum. The middle third is just anterior covering, and then the lower third has no peritoneal covering. Does that make sense?
Yes, sir.
Okay. Anal sphincters we touched about before, but again, just to recap, that you've got the internal sphincter, which is a continuation of longitudinal muscle, and the external sphincter, which is formed by levator ani. Just to recap again, these figures are from Australia, and not necessarily from Fiji, but we see about rectal cancers, about 30% of all colorectal malignancies that we see in Australia. Colorectal cancer is the third most commonly diagnosed cancer in Australia, and the second most cancer-related deaths. And the incidence of rectal cancers we see is higher in men than women. Again, talking about pathophysiology, so we know that it's well established that colorectal cancer has a precancerous stage in the form of a polyp, which then acquires additional mutations through different molecular pathways to become an invasive lesion. Dr. Parnett, can you tell me about some different molecular pathways, or what are the different pathways that you know of developing a colorectal cancer?
So one of the pathways is the polyposis, the APC gene mutation pathway.
Yes. Yep. So that is part of it. So that's I think you're referring to the adenoma to carcinoma sequence.
Yes.
Which is the APC gene mutation, and that's you're very correct. That's responsible for the majority of cases. Okay. The serrated pathway, which is where you get KRAS and BRAF mutations, is the next most common pathway. You can get the CAMP pathway, and then there's also familial pathways as well. Again, to recap, we won't go into too much detail there, but again, the main thing is the adenoma to carcinoma sequence, where you get a stepwise mutations, which will go from normal colon to adenoma to carcinoma through a stepwise accumulation of genetic mutations, which will then develop into a cancer. Again, there's a clear pre-malignant and then post-malignant stage. It's interesting that looking at this figure, that entire sequence from normal colonic mucosa to a cancer on average takes about 9 years. And again, as we know, the risk of malignancy increases with the risk of size. We won't. We'll skip over these different pathways. Presentation-wise, is that in Australia, we see a lot of these people present with asymptomatic, so fecal occult blood tests. So in Australia, we screen people from the age of 50 to 74 with a second yearly fecal occult blood test, as well as people who undergo asymptomatic surveillance colonoscopies. And then symptomatic, similar to the presentation that Dr. Hardik presented before, is that PR bleeding, altered bowel habits, tenesmus, and again, acute presentations with bowel obstructions or perforations. Again, the role of screening is to try and detect these cancers before they become symptomatic, to get them at an earlier stage, to therefore improve patient outcomes. Diagnosis and workup. Things that we think about is doing a bedside examination. Obviously, a rectal examination is critical. and we're looking at how far the tumour is away, and it's also assessing sphincter tone and function, and an abdominal examination, including examining the inguinal regions. We do bloods, including a CEA, which Dr. Hardy also presented there. We want to do a colonoscopy on the patient. Ideally, if we can, to do a complete colonoscopy, because a synchronous cancer or tumour is occurs in about 5% of patients, and is important to make sure they don't have. Again, we're also endoscopically looking at what the tumour location is, distance to anal verge, and relationship to sphincters. Radiology-wise, we're doing a CT scan, mainly to see whether or not the patient has got distant metastatic disease, and we're doing an MRI to assess, as we mentioned before, what's the T stage of the tumour, and whether or not there's any nodes involved. Staging. Dr. Niraj, are you able to talk me through? Do you know the T&M staging for rectal cancer, and can you give me some details about that, please?
Sure, sir. I can remember some on the top of my head. So for rectal cancer.
For rectal cancer, yep.
For TNM staging, it's tumor, nodal, and metastasis. With the tumor, if it's T1 disease, then it's limited to mucosa and submucosa. With the T2, it's extending into but not through the muscular propria. And then T3 is invasion into perirectal fat, and T4 will be invasion into other pelvic structures, adjacent structures. Nodal disease and not will be no involvement of lymph nodes.
Yep.
And one will be fewer than 4, less than 4 nodes involved.
Yep.
And 2 is more than 4 original nodes involved, and N3 will be distant nodes.
Good.
With metastasis, it's M0 and M1. So it's either no metastasis or distant metastasis present.
Excellent. Fantastic. Good. Neoadjuvant treatment. Dr. Parnett, is there any radiotherapy available in Australia, in Fiji? Do you guys have much experience with radiotherapy?
No, Dr.
Okay, I might I'll go through. So this is locally here in Australia. We deliver we often give neoadjuvant treatment. The main thing is Dr. Niraj, why do we give radiotherapy? What's the point of giving radiotherapy beforehand?
To downsize the tumor, I believe. Downgrade.
Sometimes it will help with that, but not necessarily. Most of the time it's fine. If we're not, does anyone else know what's the reason? What is the proven benefit of giving neoadjuvant radiotherapy?
It decreases recurrence rate and prolongs cure rate. Yeah.
Perfect. Yeah. So the first part is right. The second part's not. So first of all, radiotherapy, the simplistic way is radiotherapy decreases local recurrence of tumour. However, Celeste, that it does not improve overall survival. People don't live any longer because they get radiotherapy, but they do have significantly decreased rates of local recurrence, but it does not improve how long someone lives for, which I think is always interesting. In terms of, there's two main types of radiotherapy that we give here in Australia. One is short course and one is long course. Most hospitals will give long course, but some will give short course. So essentially, short course is where you get 25 grays of radiotherapy over 5 days. And we then operate on that patient 4 or 5 days later. So you need to operate on them in a very short period of time. Long course, they get 50 graves of radiotherapy, and we give it daily for 5 days over 5 weeks, and combine it with chemotherapy, which is an oral-based 5FU chemotherapy. And we operate on that patient about 8 to 10 weeks post the completion of their radiotherapy. So that time frame is generally being extended out. Previously, it was around the 6-week mark, and we're now extending and pushing that out further to the 8, 10, and even sometimes 12-week mark. Dr. Salesi, what's the reason that we give? What's the reason we give chemotherapy? Do you know, during radiotherapy?
Is that to destroy all micro cancers around the body?
Good suggestion, but no, it's not. It's actually, it doesn't treat any micrometastatic disease, but it's a radiosensitizing chemotherapy. Essentially, it's not a true systemic chemotherapy, but it's radiosensitizing. By giving this chemotherapy, it makes the tumor more sensitive to the radiotherapy, and therefore increases the effect associated with that. Is the main thing. Again, as we talked about, is written here. So the take-home points are: you can either give short or long course radiotherapy. We're doing it to reduce local recurrence. It doesn't have any long-term survival benefit. However, it can help, as mentioned, to downstage some tumours, and in some cases can enable sphincter preservation and achieve a negative margin, which wouldn't be given. Again, as we mentioned before, we give radiotherapy to mid to low rectal tumours that are either T3, T4, or have nodes that are affected. Again, we don't give it to upper rectal tumours, the main reason being because it's above the peritoneal reflection, you're unable to give adequate doses of radiotherapy because of the potential issue with small bowel toxicity. All right. Who haven't I asked questions to? Dr. Kanong.
Yes.
Can you please tell me about different surgeries, or what surgical options are there available for the treatment of a rectal cancer? Can you give me some broad principles?
Principles. So principles. You mean so in rectal cancer, we involves hemicolectomy, right or left, or anterior resection, anterior rectal resection. So
yeah, but what are the different types of operations for rectal cancers?
Not sure.
No, that's fine. So again, I think the principle, it depends on where the tumor is located, what's the relation to the anal sphincters, and what's your ability to get below the tumor and preserve that sphincter's function. Okay. So in terms of surgical resections, the way that kind of the broad principles of the broad type of operations are either an anterior resection or an abdominal perineal resection. And those anterior resections are then broken down into high, low, and ultra low. And essentially, the way that we classify them here is how far away your anastomosis is from the anal verge. So if you're in 10 to 15 centimetres from the anal verge, call it a high anterior section. 6 to 10 centimetres from the anal verge, call it a low anterior section. And ultra low is less than 6 centimetres from the anal verge. And then obviously, Dr. Kanong, do you know what an abdominal perineal resection is?
No.
Dr. Kanong? Or maybe Dr.
That's-
No, that's fine. What about Dr. Neelam? Can you tell us what a abdominal perineal resection is? Dr. Javilli.
Hello, yeah. So APR is basically removing all of the rectum, complete major rectal excision, including the anal sphincters.
Yes.
Yeah. So yeah.
Yeah. So resections of the rectum, anus with a permanent encephalostomy. Principles. So I thought these are some principles that I wrote down that I thought are important for any rectal cancer operation. And again, this isn't everything, but these are, I think, things that go about any type of operation for rectal cancer. So one is the margin. So it's about how far our distal margin in. For high tumours, we like to aim for a margin of 5 centimetres. And again, that's similar, or that's what it is for colonic cancers. However, for mid to low rectal tumours, we aim for 2 centimetre distal margin. However, there's pretty good evidence to show that 1 centimetre is satisfactory. And there's even more of a move now towards showing that no incon tumour or just a microscopically clear margin is appropriate management. But we're still aiming for that 1 to 2 centimetres. A total mesorectal excision, as we touched on, is appropriate. Is appropriate for another principle. We think about preservation of bowel, bladder, and sexual function when we're doing our dissection. Again, the main way of doing that by staying in our TME plane and allowing and preserving those autonomic nerves which go down to the pelvis. Restoration of bowel continuality, either with a end-to-end anastomosis or with a colonic J pouch. The role of a defunctioning loop ileostomy. Dr. Michelle, when do you think a defunctioning loop ileostomy is used in rectal surgery, or when would you consider using this?
We'd consider an ileostomy in any anastomosis that we do, so to preserve, to allow healing of that anastomosis.
Yeah. Yep. And so would you do that for any rectal anastomosis, or would you do it for some? What would you think about?
So in Fiji, it's difficult to look after an ileostomy.
Yes.
So not in all cases, I think will be specific patient.
Yeah. And Michelle, what is the role? Why do you give someone an ileostomy? What does it actually do to your anastomosis?
It prevents the bowel contents from passing through the anastomosis, so allows it to come out through the ileostomy.
Yeah. So
and allows healing of the
does it decrease
anastomotic
your risk of anastomotic leak?
And prevents maybe stretching and leakage. Yeah.
But hold on, just think about my question. Does a loop ileostomy decrease your risk of an anastomotic leak?
Not really, because I think an ileostomy will be quite higher than there'll still be secretions and things going down. So not really sure.
That's fine. So tricky, because the short answer is it does not decrease your risk of an anastomotic leak, but it decreases the clinical significance, or it decreases the impact of that leak. For example, anastomotic leak and you're covered by a loop ileostomy, then you're very likely, or the patient has a much greater chance of not requiring return to theatre and being able to manage that anastomotically conservatively. They require antibiotics, they might require pain, but the clinical significance, the impact of that leak is much less than if they're not defunctioned. However, you are still, your actual risk of anastomotic leak does not change with a lumpectomy. Does that make sense, Michelle? We'll move on to next per lymphovascular pedicle. So
Yes,
again,
yes, sir.
yep. Dr. Javilli, why do we want to take the lymphovascular pedicle that's associated with the tumor?
So yeah, the venous drainage of the left colon going down to the proximal rectum follows up the inferior mesenteric artery. So we have to get a complete clear nodes, then we'd have to ligate it further up. One, and the other one is for gives you better reach if you need to do a low anastomosis, so lesser tension on your anastomosis.
Yes. Yeah, exactly. Perfect. So yeah, we want to take the nodes out to appropriately stage the patient, and we also, well as appropriately staging the patient, we also allow us, as you said, enough mobility to be able to restore bowel continuity. Correct. And then finally, hold on, sorry, let's move this. Finally is the surgical or rectal total mesorectal excision. Again, I'll just this briefly. I know we've mentioned a number of times, but it really is one of the key surgical principles. This was actually taught by Professor Bill Heald from, I'm not sure he was from a regional county hospital in England. And he first published his work in 1982, and it's become mainstream practice since the late 1980s. Total excision of the mesorectal envelope, which is done at direct vision with sharp dissection in an avascular plane. And again, as we all know, it allows that, it develops that intact fascial envelope between the pelvic fascia, which allows complete removal of the tumor with an intact mesorectal envelope. Really, the key benefits of doing this is decreasing local recurrence of the tumor. It allows preservation of those pelvic autonomic nerves, which we talked about, which are important for reducing the incidence of post-operative sexual and bladder dysfunction, as well as a decreased risk of presacral bleeding by avoiding getting into the presacral venous plexus. The figures are, I think, are quite stark. That prior to TME, there was a 20 to 25% risk of local recurrence of a tumor. However, after TME, that's been decreased down to 5 to 10%. So has obviously been a significant change in the management of rectal cancers. On a bit of a side note to that, there is this concept, as you might have heard of tumor-specific mesorectal excision. This involves or is applicable to tumors in the upper rectum, and it involves partially dissecting in that TME plane. However, instead of following the TME plane all the way to the pelvic floor, we perform a mesorectal excision 5 centimeters distal to the tumor, and then transect the mesorectum and perform our anastomosis then. Again, I looked up the current guidelines from the American Society of Colorectal Surgeons, which define as a or they have recommended that as a curative resection of tumours in the upper third of the rectum, a tumour-specific mesorectal excision should be performed as part of a low anterior resection with the mesorectum divided, ideally at least 5 centimetres below the distal margin. Again, for tumours in the middle and lower thirds of the rectum, a total mesorectal excision should typically be performed as part of an ultra-low anterior resection or an APR, i.e., if you can get 5 centimetres below an upper rectal tumour, you don't need to follow that TME plane all the way to the pelvic floor and do an ultra-low. It is appropriate to transect the mesorectum 5 centimetres distally and therefore perform what is called a tumour-specific mesorectal excision. Surgical approaches to rectal dissection, and again, this is not directly applicable to your work in Fiji, but I thought was an interesting thing that I read in a recent paper published a couple of years ago. This is talking about the different approaches which are now currently possible for rectal dissection, and this is really talks about the different benefits. Really, there's a number of different methods that is able to be used for approach to rectal dissection. That's a combination of either an open dissection, a laparoscopic dissection, using the robot to dissect, using TAR-TME, which is a keyhole approach from distally from the tumour to then go proximal, and also the potential role of TAMIS, where you do a laparoscopic resection of the tumour from within the lumen. This is just an example of the setup that we use for either a TAMIS or a TAR-TME, where we use a gel point pack inserted into the anus, and then use laparoscopic instruments to go down and to resect a tumour from the anus itself. Histology. I should ask someone, Dr. Uriam. Can you tell me when you get your histology back, what are the features that are poorly prognostic on the pathology?
Hello. Can you hear me, sir?
I can indeed.
Hello.
I can hear you, Dr. Uriam. Tell me.
Yes,
yeah, what features on histology are poorly prognostic?
First of all, sorry, I have a bit of connection problem here from here, but I think that one of the most important investigation is to confirm the pathology is this histopathology of the sample.
Yes.
And then most important, we call it parameters that we take into account is the grade of the depth of the penetration.
Yep.
The disease.
Yes.
Also, you also assess the number of positive lymph nodes.
Yes.
The invasion, whether they invade the lymphovascular tissue.
Yep. So lymphovascular invasion. Yes, definitely. Yep.
And or any tumor deposits. Those that I can remember.
Oh, that's fine. So yeah. So tumor itself that we're thinking about histopathology and features. So we're thinking about T4, so penetrating visceral peritoneum. If there's any obstruction or perforation present, poorly differentiation, and then lymphatic, venous, or perineal invasion are all poor prognostic factors. As you mentioned correctly, lymph node disease, and obviously any distant metastases or a positive tumor margin, either circumferentially or distally, is going to be difficult. In terms of adjuvant chemotherapy, again, the intricacies are slightly different compared to rectal cancer. because it all depends on whether or not the patient's had neoadjuvant treatment before. But in short, treatment of adjuvant chemotherapy, this is for colonic cancer. Really the clear benefit is for patients who have positive nodal disease. So they have an absolute survival benefit of 5 to 6%. Whereas stage 2 patients, so patients that are T3 or T4 disease, have a relatively minor absolute survival benefit from adjuvant chemotherapy. So that's really a 2 to 3%. And patients who we consider in Australia for adjuvant chemotherapy is those with high risk stage 2 disease. So those people who have perforated, obstructed, poorly differentiated pathology or T4 disease, we consider adjuvant chemotherapy for, but there's no role for low risk patients. Again, I think rectal cancer is a very exciting area of general surgery. There's a lot of intricacies and a lot of nuances involved in that discussion. I listed here just a number of those different topics that we often talk about here as evolving treatment modalities for rectal cancers. That's the end of my presentation, which I'll close here. Does anyone have any questions about anything that we've talked about?
Yes, Doctor. Just about the tumor-specific mesenteric excision,
yes,
where you don't do a TME the whole way down.
Yes.
Does that affect how far your distal portion of the bowel would be released? Would you have a shorter distal portion, making the anastomosis more difficult?
Yeah, so if you do, so yeah, tumor-specific mesorectal excision, as we said, it's really for high rectal tumors. So for an upper rectal tumor, if you're able to get 5 centimeters below it, but you're still maybe in the middle of the rectum, what a tumor-specific mesorectal excision is, that saying that you don't need to go all the way to the pelvic floor, that you can divide the rectum 5 centimeters below the tumor, say it might be at 8 or 9 centimeters, to divide the rectum there. And therefore, yes, you will have a longer rectal stump, but you will then anastomose or join onto that longer rectal stump, compared to if you if you're instead going all the way to the pelvic floor and leaving a stump that's only, do you know what I mean, 3 or 4 centimeters long.
Okay, yeah.
In terms of the benefits of doing that is less dissection, your anastomosis is further away from the anal verge. That will decrease the risk of an anastomotic leak. And there may also be some improved post-operative function in the patient because you're leaving more rectum in them. So they may be able to, they may have less issues with their bowel function after the operation.
Okay, yeah, thank you.
One thing we didn't cover was that we often see here is low anterior resection syndrome. Dr. Ashneel, do you know what low anterior resection syndrome is? Have you come across it before?
Sorry, no, probably a good topic to read up on.
Has anyone come across low anterior resection syndrome or anterior resection syndrome?
No, I've not.
No. So, low anterior resection syndrome, something that it's essentially, it describes a constellation of symptoms after someone has an anterior resection. Essentially, it relates to patients who have frequent bowel motions. I'm sure everyone's seen this. Patients who have an anterior resection or an ultra low or a low anterior, or they've just had part of their rectum removed, that often they will have lifelong issues with their bowels. Their bowel function will never return to normal. That they will have issues with ongoing frequency and urgency that's associated. And really, when you define those symptoms, everybody or nearly everybody will have those symptoms early on in their post-operative phase. However, as things progress, or as do you know what I mean, time progresses, and again, different time people define or can diagnose someone with low anterior section syndrome after. Some people say 3 months. I think probably 6 months is a more appropriate time that you then diagnose them with low anterior section syndrome, and the main treatments are fibre supplementation and the use of loperamide to try and slow down their bowel function. And one of the things that's getting increasing popularity in Australia is the use of sacral nerve stimulation to treat their low anterior section syndrome. Does anyone else have any other questions?
So sorry, Dr. Henry. So like you've said, just the chemo for rectal cancers is just basically for radio sensitivity, right? Radiation sensitivity. That's all, right?
Yes, that's the neoadjuvant chemotherapy, not the adjuvant chemotherapy.
Oh, okay.
Yeah, just for neoadjuvant. Neoadjuvant chemotherapy is just radiosensitizing. However, adjuvant chemotherapy afterwards is to treat their micrometastatic disease. And that's a systemic form of chemotherapy. It's just the adjuvant chemotherapy that's given beforehand.
Yes, because we only have 5FU here, and it also depends on when we have it. It's mostly donated drugs, or if it's through some kind of donor agency that gives it to us, a 5FU.
Yeah, okay. All right. Do many patients get chemotherapy after their rectal cancer resections in Fiji?
So it's just like that. I mean, it depends on the availability of the medication and the life expectancy of that patient. And so we discuss all that before we can start giving this chemotherapy.
And go from there. Okay, all right.
Sorry, so would you give a adjuvant chemotherapy to a T2 rectal tumor?
Complicated question, Celeste.
Doc, I had a question.
Oh,
So what's...
Oh, hold on, Michelle. I'm just going to
what
answer
do you
Celeste's
think...
question first. Yes, so Celeste, so that depends on a number of different factors. We because it really depends on if they had not had any neoadjuvant treatment, then no, we would not be giving them adjuvant chemotherapy. However, the discussion's much more complicated if they've had neoadjuvant chemoradiotherapy, and that's something we discuss in our multidisciplinary meeting, and we discuss it with the radiation and medical oncologists and decide whether or not there was a benefit to them completing it. But no, if they had not had neoadjuvant treatment and they just had an upfront T2 cancer, then no, we wouldn't often treat that.
Okay, yes, thank you.
Sorry, Michelle, you were saying before?
I think her connection is a little bit delayed, so just wait for her.
Sorry, my network keeps dropping off. I just wanted to ask what your recommendations are for follow-up surveillance.
Yeah, good question.
Are you able to hear me?
Yep, good question. Our surveillance, again, I'm not sure what your surveillance protocols are in Fiji, but we survey or we follow up people here in the hospital that I'm working in Geelong. We follow up people, everyone, for 5 years afterwards. And so essentially what that involves a combination of colonoscopy, of doing CA blood tests and doing CT chest, abdomen and pelvis. We do a colonoscopy on patients 1 year post their resection, and then we do it every 3 years after that. In contrast, we then do a CT chest, abdomen and pelvis every 12 months, so every year up until 5 years. And we do a blood CEA initially every 3 months for the first 2 years, and then we do it every 6 months after that. Does that make sense, Michelle?
Sorry, so for the CEA again, initially every 3 months?
Every
And then-
3 months for the first 2 years, and then we do it every 6 months for the for years 3 to 5.
Thank you. How often would you do a colonoscopy for a polyp that you'd find?
Yeah, so that would all depend on what the histology of the polyp is, and histology and the size of the polyp. If we do a polyp, if it's just a small low grade tubular adenoma, we do a colonoscopy in 5 years. If it's greater than a centimeter, or if it has any high grade or villus features, then we do a colonoscopy in 3 years. Is our standard follow-up after a polypectomy.
Sorry, one more question, Henry. So if you have a patient that has a low rectal cancer with
Yes.
palpable inguinal lymph nodes, would you do a inguinal lymph node dissection?
Yeah.
Or is
so-
it staged clinically? Yeah.
Yeah, so we'd stage that patient with an MRI and with a MRI and a CT scan. That's the patient, if they've got palpable inguinal lymph nodes, they're probably very advanced, and most of the time these patients will have metastatic disease. The one of the situations that we sometimes see is patients who have lateral pelvic lymph nodes. And there's a lot of controversy around what we do with lateral pelvic lymph nodes. Kind of the Western approach to that is to treat them with neoadjuvant chemoradiotherapy and irradiate, and the radiation oncologist will extend the radiation field laterally into the pelvis to capture these nodes. However, the Japanese or the Eastern approach is being to do lateral pelvic lymph node dissections. It's a difficult operation with a lot of morbidity associated with that, but it's kind of gaining some popularity in Australia at the moment anyway. And that's actually one of the current controversies in colorectal surgery at the moment, is what is the role for a lateral pelvic lymph node dissection when you're dealing with a locally advanced rectal cancer. I think I don't think there's any right or wrong answer to that at the moment. And probably the consensus is that radiotherapy we treat them with first, but in nodes that don't respond to radiotherapy or persistent, there may be a role in surgically excising them.
Yes. Okay. Thank you.
All righty. If that's everything, guys, we might call it an end. Paneet, are you
Yes,
I think
yes, Dr. Henry.
you're happy with everything, guys? If no one's got any further questions, we might call it a night.
Oh, yep. Okay. Thank you, Dr. Henry, for all this this class, and we would like to hear from you again in the future. Definitely.
Sounds good. Thank you. Thanks very much for organising, Dr. Paneet. I hope everyone has a great night. Fantastic speaking to everyone again.
Thank you. Thank you, sir.
Thank you.
Thank you, sir.
Bye.
Bye.